Hi, Papicho.
Hey, I'm good. How are you?
Good, and you?
You're good?
Okay, okay. But I'm the one who's starting this. Is it okay? Or maybe to teach Mariam to start it? Okay.
What's going on?
What did you say? Hello?
Yes, how are you?
Good, thank you. You're
Okay.
asking something?
Yes, I think I'm the one who's starting the webinar. So maybe for the other stuff, is it okay, Mariam? Or maybe you have to
Um,
take.
if you if you don't mind making me the host just so I can get the recording, you
Yes,
should be
yes.
able to change it.
Yeah, let me make you the host.
Thank you.
Yep. It's done, Mariam.
Thank you. I just got it.
Good morning, good afternoon, everyone.
Good afternoon, Papa. How are you?
Good, good. Just testing my microphone.
All clear.
I see, I see. You are very clear.
Thank you.
And thank you to the attendees who are already on the line. We'll be getting started in about 5 minutes when our other panelists join. Thank you all for joining Gradient Health Systems Critical Care and Anesthesia webinar. We appreciate all of you being online with us today. And thank you to those who have joined several of our presentations over the last year and a half. I'm going to kick off. My name is Miriam Khan. I am the head of communications for Gradient Health Systems. And I am just going to run through some of the housekeeping notes up front, and then we'll turn it over to our moderator, Dr. Ndaba, to get us started. If you have any questions during the webinar, please use the Q&A feature to ask us. We will have time at the end to answer questions. If you have any issues during the presentation or have any comments, you can also use the chat function, and we will all be able to see that. The webinar will be recorded, and you'll receive a copy of the webinar, a recorded copy of the webinar after the webinar by email. If you don't get it for some reason, you can access it on our website, gradienthealth.org, under the training section, or on our YouTube page as well. And then we're also always looking for feedback. If you have any questions or feedback or any thoughts on any other topics that we can cover, please don't hesitate to reach out to us at customers@gradienthealth.org. And I'll turn it over to Dr. Ndaba now to introduce our presenter and to talk about our webinar this afternoon and morning.
Thank you so much, Mariam. Good morning, good afternoon, good evening to you all, and thank you for joining us. My name is Dr. Ndaba Spuka. I'm a physician anesthetist from Zambia. I'm going to be the moderator for this session. So I'm going to introduce our presenter for this very, very important topic. So today we are discussing principles of anesthesia for a patient with an underlying cardiac disease coming for non-cardiac surgery. So our presenter for this afternoon would be Dr. Kevin Omani. Dr. Kevin Omani is a cardiovascular anesthetist. He's based in Kenya. He's got vast experience, so he will take us through the session. Then we'll have another session of where we're going to spend time discussing various questions and concerns from the participants. So we are going to encourage you to actually ask as many questions as you can, share your experiences, and indeed, we are also willing to learn from you as well. So at this particular moment, I'm going to invite our main presenter, Dr. Omani, to start with the presentation. Dr. Omani, are you there?
Okay. Good afternoon. I know some people on the other side. Good evening or good morning, wherever you are. Thank you for finding time to attend the webinar. So I'm going to discuss patients with cardiac disease for non-cardiac surgery, which is actually a topic that is actually mainly that's actually discussed whether you're a physician or non-physician. I think it's part of the curriculum. Looking at the trend of cardiovascular disease in our continent, it's not surprising that we are going to see more and more of these patients. So it's good to have an idea of how these patients are managed based on what is presenting. Okay, we can move to the next slide. So I'm going to talk briefly on the introduction. So here I'm just going to focus more on a brief outline of the physiology that's applied to these patients. We'll also look at some of the key aspects in preoperative assessment and risk analysis. Then we'll discuss what to do with patients with ischemic heart disease and patients who are presenting already, say, with decompensated heart failure, probably due to some various causes, then valvular heart disease. So these are quite, especially valvular heart disease is quite common in our region. And then I'll conclude. Next. Hello, next. Yeah. So every physician anesthesia provider, whether you're a consultant anesthesiologist or whether you're a clinical officer anesthetist or a nurse anesthetist, this is a very important equation that you must keep in mind. And once you understand what it entails, then you'll be able to make decisions when there's hemodynamic instability in theater. And I'll just emphasize on some aspects of it. And it's something not to forget as long as you're practicing your anesthesia. We know that cardiac output is the volume of blood pumped by the heart each minute, which is a factor of your heart rate, which in pediatric patients, it plays a very big role compared to the stroke volume. The stroke volume is now what plays quite a very important role as children develop towards teenagers and adults. And the stroke volume maintains three main entities. That's your preload, your afterload, and contractility. Your heart rate is quite important because if you've seen, if the rate is quite low, then the ejection is quite very poor. At the same time, also, if the ejection is too fast, it's also not, if the rate is too fast, it's also not good for the heart because it limits diastolic filling. So that's why you find the sympathetic innervation, which plays a role in regulation of the heart, also in correlation with the parasympathetic, are quite very key. We also see sometimes there are patients who are on different medications also to regulate their rate, particularly in patients with arrhythmias. So preload is basically the degree to which your ventricles are stretched at the end of diastole, and that contributes filling. Well, afterload is now the force or the resistance which the heart must work against. And contractility basically is how your heart is able to, how able is the force of contraction that comes about, contributed also by your rate. So your stroke volume is a product of end diastolic volume and your end systolic volume. So if your your end diastolic volume is about 120 mils, so your end systolic volume is usually about 70 mils. So that's a difference of 50. So if you multiply by your rate, if you multiply by your heart rate, you get your cardiac output. So if it is once you get that difference, so if your rate is 80, and if your rate is 80 beats a minute, and the difference between your end diastolic volume and end systolic volume, which is your stroke volume, is what gives you your cardiac output. So usually the end diastolic volume is around 120, your end systolic volume is around 50. So that's 70. So 70 multiplied by 80 gives 5,600, which is about 5.6 liters. So that's your cardiac output. So you can imagine when somebody suffers major trauma and loses, say, more than 40% of that, that's actually massive blood loss, right? So that's about how important your cardiac output is. Next slide. So the Frank-Starling curve is also something we should understand. If you remember the Frank-Starling law, which means the greater the end diastolic volume, that means the greater the degree of stretching, and that means the force of contraction will be very strong. If you look at this graph on the upper part, if you look at the end diastolic volume on the y-axis, on the x-axis you have your stroke volume. So you find that as your heart is feeling, which your end diastolic volume is 120, which is usually almost towards the upper limit. So this is where it reaches plateau. So beyond this, the heart may not feel anymore. And when there's when your your stroke volume, which I said is a difference between your end diastolic volume and end systolic volume. So usually we get a stroke volume of 70 because the end systolic volume is around 50. So in a failing heart, the situation is different. So a failing heart can come about because of different pathologies. Example, it can be valvular heart diseases. It can be even ischemic heart disease. So in a failing heart, as you tend to feel more, it's not going to generate a good stroke volume. Because already the force of contractility, that is whether it is systolic or diastolic type of failure, reduces the capacity of the heart generating a good stroke volume. So what this graph is telling you that when you deal with a failing heart, if you give too much fluid, this patient is actually on the lower side, and that's not good. Because his left end, as much as you feel and there's no contraction or there's a poor output, the heart is not able to eject. So you find the stroke volume is actually on the lower side. And this is a heart that may need some form of support through inotropes. And also, as you tend to overload it with fluids, the left ventricular end diastolic pressure becomes increased. And when that happens, the heart consumes more oxygen and tends to work hard, and it even makes it deteriorate, and the patient gets a cardiac arrest. So the take home from this slide is, remember, a patient whose heart function is very poor is on the lower end of this Frank-Starling curve. And it would not be good to overload him with a lot of fluid. Okay. Next slide. So whenever we face these patients, we should keep in mind that cardiac dysfunction, yes, it may pose a challenge to our anesthesia conduct. But that does not mean that these are patients who should not be able to be done surgery. This is why you find that as we go on in the presentation, we are going to look at risk analysis or risk assessment so that you can be able to analyze the situation and be able to look at if the patient needs any optimization, or probably he's a patient who is stable and the procedure can be done. But yes, the functional capacity can pose a challenge. Just please go back. Yeah. And these cardiac complications contribute to perioperative morbidity and mortality. Particularly these patients, when they have cardiac dysfunction, they may have arrhythmias. Their heart failure may be in a stage of stage 4. So you find that they can't even tolerate probably IV induction, and that can trigger cardiac arrest. Or sometimes these patients could be recovering from a previous ischemic event, and hypotension itself can cause myocardial ischemia. Next slide. Yeah, so patients with cardiac disease present with various symptoms. So particularly many of them complain of exertional dyspnea. This is dyspnea which they complain about, especially if they're doing, if they're walking, or if they need to do a strenuous climb, like climbing a stairs. They may also complain of orthopnea, that is dyspnea on lying down. If they have ischemic events, that is proven myocardial infarction through an ECG or the history itself, like unstable stable angina, which is chest pain that is provoked by strenuous activity, but it relaxes when at rest. Then they may complain of palpitations, particularly if it's an arrhythmia. The most common arrhythmia you'll face as anesthesia providers is the most common arrhythmia is atrial fibrillation, but that's a topic for another discussion. But it's not surprising that you hear patients with atrial fibrillation complaining about palpitations. These patients can also have comorbidities, so it's not surprising their diabetes and hypertension is contributing to their heart condition, particularly ischemic heart disease. And because of also decompensated heart failure, you may also get chronic renal failure, or your hypertension and diabetes is causing chronic renal disease. Yeah. So a physical exam is important, particularly looking at if the patient is showing facial puffiness, fluid overload, which are signs of fluid overload. So they may have facial puffiness, distended jugular neck veins. When you auscultate the chest, you may hear basal crackles, which is showing an effusion. They may be murmurs. Then they may also have effort tolerance. So you may find they may complain of things like exertional dyspnea. These patients may have anemia of chronic disease. So it's not surprising some of these patients, anemia of chronic disease, particularly if they have comorbidities, like diabetes, or you may find if they have chronic kidney disease on top of that, because of erythropoietin, deranged renal functions. ECG may show arrhythmias or ischemic changes. Chest X-ray may reveal probably things like cardiomegaly or pulmonary edema. And an echocardiogram may just probably reveal an underlying pathology like valvular heart diseases. Next. So this is a common risk assessment tool that I came across that is actually recommended. And it's important that we get familiar with it. So, and it's quite very simple to use, but it doesn't per se change the outcome of how the patient is. It gives you an idea of some of the possibilities that may pose a challenge to the patient. So history of ischemic heart disease, a patient scores 1 point. If there's a high risk type of surgery, particularly if it's an if it's a thoracic procedure or a major abdominal procedure where you're anticipating blood loss, if there's congestive cardiac failure, So patient complaining of exertional dyspnea, orthopnea, plus even evidence on physical exam. There's one point that is scored. If there's history of a stroke, preoperative treatment with insulin, and preoperative serum creatinine of more than 2. So those score 1 point. So if there's 3 or more, it means the patient has quite a risk of a major adverse cardiac event. So if there are those risks of major adverse cardiac events, then it is you as the anesthesia provider to keep in mind that they may happen, and how do you navigate? So that's the most important thing. So just like, for example, as how pilots try to land a plane when there's very strong crosswind. So it's either you decide to land the plane or you chicken out and you decide not to land. So that's why I'm saying when you get to see the risk of major adverse cardiac events, it's your duty as the anesthesia provider to navigate and see what can be done. And if there's a risk of morbidity, mortality, where you find the risks outweigh the benefits, then it's probably wise to discuss with the surgeons on whether this case needs to proceed or not. Next slide. So these patients may be on different drugs. So patients may be on beta blockers, some patients may be on antiplatelets, others could be on drugs like nitrates and calcium channel blockers. So beta blockers are drugs that are important in controlling your heart rate. They must not be stopped if a patient is on it. So please, if a patient is on a beta blocker for his hypertension or is on treatment for heart failure, even if he's going for surgery, it's important that it continues. Please don't say beta blockers should be stopped or you remove them from the list. Yeah, there's a reason why they have been put. So patients on heart failure, they are mainly given to control the rate because of sympathetic stimulation. Some of drugs like aspirin, clopidogrel. So aspirin should be continued except in cases where there's intracranial surgery or spine surgeries where you're anticipating a lot of bleeding. Clopidogrel, generally it is stopped 5 days before surgery, but some cardiologists may prefer it to be continued, particularly where you find their surgeries where the risk of bleeding versus the risk of not performing the surgery is crucial. So surgeries where there's minimal bleeding, for example, probably a hernia and a patient is on clopidogrel, then you need to discuss with the physician or the cardiologist on what will happen if you stop it, which may cause a clot. And that can be detrimental to the patient versus bleeding that may happen for the surgery. So those are discussions that need to go hand in hand with the physician and make a choice. Nitrates, calcium channel blockers, those ones are, can be continued. AC inhibitors, if a patient is taking them in the morning, you skip them. If probably is taking them at night, there's no harm continuing. The danger is them being given in the morning. Them and ARB blockers or angiotensin receptor blockers, because they cause vasoplegia. And this is very bad, profound hypotension. Yeah. Sometimes it may be quite resistant even to ephedrine or phenylephrine, and you may need to tone these patients with norepinephrine. Okay. So keep in mind these drugs, ACE inhibitors and ARBs, they are emitted on the morning of the surgery. Next slide. Hello, next slide. So I've put this illustration. So ischemic heart disease basically is your coronary arteries being clogged by clots over a long period of time, particularly when in conditions such as hypertension, where you find there's atherosclerosis, so it causes platelets to congregate. And at the end, you find there's lack of blood flow, as you can see on that slide. Hence, there's no oxygen and no nutrients. So the myocardial muscle dies. So this is where you've heard of myocardial infarction. So an infarct is basically a dead tissue. Next slide. So when you're dealing with these patients, you should keep in mind these two things. So oxygen supply basically means factors that influence distribution of oxygen. So you need to think about vessel diameter. And for that vessel diameter, there obviously needs to be flow in terms of pressure. And also the oxygen content. Yeah. So oxygen demand simply means the consumption. Yeah. So if you have a fast heart rate, it reduces your diastolic time. Your coronary perfusion pressure is contributed a lot by a diastolic pressure. So when your diastolic pressure is reduced, then the coronary perfusion pressure will be very poor. It's particularly in patients with aortic regurgitation. Then also your left ventricular end diastolic pressure, when it increases, it compromises microvascular flow. Oxygen content, your hemoglobin, when hemoglobin is low, the danger with low hemoglobin is simply it disturbs the oxygen carrying capacity. Yeah. And when that happens, that means your cardiac output has to increase. Then your arterial oxygen partial pressure. This is mainly because of your usual ventilation. So that's why you find hypoxia is dangerous to the heart. So especially when a patient has got ventilatory compromise, that's going to affect your arterial oxygen partial pressure. When you have anemia, it's only that anemia per se itself, the danger with anemia is that you have got less red blood cell molecules. So when there are less blood cell molecules, there's less oxygen distribution. So your heart needs to work harder by ejecting and taking oxygen from your lungs to push faster than your coronary artery vessels diameter. Heart rate, ventricular wall tension, and contractility influence your demand. So in a patient with myocardial infarction or ischemic heart disease, a fast heart rate is going to consume more oxygen. And if his heart is recovering from a very bad coronary artery diameter, then wall tension, which is played by preload and afterload. We saw on the Frank Starling curve. So in heart failure, the ventricular wall tension is increased, and that's dangerous. Then if your contractility is very fast, then it consumes more oxygen. Next slide. So these patients who have got ischemic heart disease and they're presenting for whether it's elective surgery or emergency, you need to avoid tachycardia. We've seen what tachycardia does. It makes your heart consume more oxygen. Then you need to maintain preload. We've seen your coronary artery diameter is quite important to allow that perfusion and also to maintain your left ventricular to maintain also your diastolic pressure. Then you have a poor preload, that's going to affect your cardiac output. You want a normal systemic vascular resistance. Yeah, so the blood pressure should be within 10 to 20% of your baseline value. Studies don't show which one is superior than the other. If a patient has got a condition above the umbilicus, it may be appropriate to use general anesthesia with cardiostable drugs below the umbilicus. Regional anesthesia is beneficial whether you're doing a neuraxial block or you're doing a peripheral nerve block. Arrhythmias are managed according to the ACLS protocol. Inotropes could be required, especially where patients have a history of wall motion abnormalities, and probably the echo is not demonstrating a poor ejection fraction. These are patients that probably may need inotropic support at induction. These are patients that may need postoperative care in the HDU, ICU, or close observation in the PACU. Next slide. Patients with heart failure. So heart failure per se is not a disease, it's more of a syndrome. So it's not enough to say a patient has got heart failure. You need to find out what exactly is the underlying cause. And this is something I believe people have come across in their earlier training as undergraduates or in other, or probably if you're a nurse in your earlier training. Yeah. So it's just a complex pathophysiologic state where you find there's a problem with either your systolic function or your heart not able to relax and feel adequately. So common causes are cardiomyopathy, especially with advanced age, hypertension, which causes concentric hypertrophy, which limits your feeling, valvular heart diseases, or ischemic heart disease because of myocardial infarction. Next slide. So when you have heart failure, your cardiac output falls. Yeah. So we've seen that it's inability of your heart to be able to either eject or feel adequately. So your sympathetic nervous system will increase your heart rate. And as a result of increasing your heart rate and increased sympathetic activity, it activates your renin-angiotensin mechanism. So which results in aldosterone being secreted, which causes reabsorption of sodium and water. And that's why you find these patients get edema, and that increases your venous pressure. And venous pressure increases capillary filtration. Okay. With time, as the disease progresses and the cardiac output falls, the blood pressure falls. Okay. Next slide. So this is a slide showing a chest X-ray of a patient with cardiomegaly. And this is how a failing heart looks. Remember, we talked about the Frank-Starling curve. So you can imagine now you overloading this patient with a lot of fluid. Definitely there's going to be a cardiac arrest. Okay. Next slide. So in these patients who have got heart failure from whatever cause, and it's important, if they're symptomatic, then these are patients that probably need to be diuresed, and they probably need things like afterload reduction, so they'll be on AC inhibitors before they come for surgery, because if they're already showing signs of fluid overload, then it's very easy for them to have a major adverse event. So that's why, as these patients, those who are stable and they're coming for surgery, it's important to maintain their preload adequately, not you striking a balance, not almost overloading them with fluid, but just giving them what is just enough to maintain a blood pressure. Usually these patients may just require small volumes of even 200 to 250 boluses and probably half maintenance. And that will help with maintaining contractility. Afterload decrease, one needs to be quite cautious with this, because also at the same time you don't want to lower your pressure, though a failing heart likes a decreased afterload because it doesn't need to work so hard to push blood. Yeah. So this is where you find some of these patients may be on drugs like nitrates or AC inhibitors. Okay. But we mentioned that they are omitted on the morning of surgery. Okay. Minimizing myocardial work by avoiding tachycardia. Those patients with poor known cardiac function before surgery may need inotropes. Regional anesthesia in terms of epidural blocks or peripheral nerve blocks are acceptable. Very important to maintain an optimal fluid balance, and these are patients for close observation in a HDU and ICU. Next slide. We are then now going to look at one of the final, we are going to look at patients with valvular heart diseases, which is now the final part. So these are quite very common in our continent. So these lesions can either be regurgitant lesions. This means a valve is not closing properly. So you find that instead of blood moving in one direction, it goes back in the opposite direction. So these patients mainly get volume overload. Patients with stenotic lesion simply means that there's narrowing. So there's less blood flow to fill a certain chamber or to move through a certain vessel. So these patients get more of pressure overload on that chamber. So there's less blood flow, and this is actually the worst compared to regurgitant lesions. So commonly in our continent, rheumatic heart disease or in the elderly, calcific degenerative changes cause, or they could be congenital causes. Next slide. So in mitral stenosis, this at the level of the mitral valve, the mitral valve is not opening. So this is quite a very common condition that you may come across. So it's important that you get to know and understand this pathology, and these are common questions in the exams on dealing with stenotic lesions because of the challenge they pose. So reduced LV filling because there's less blood flow from the left atrium to the left ventricle. So because of that reduced filling, there's going to be an increase in your left atrial pressure, and that causes pulmonary congestion. So in this pulmonary congestion, as time goes by, you find the right side of the heart will start dilating, and the patient presents with biventricular failure. These patients also are at risk of atrial fibrillation because the increased LA pressure tends to dilate the left atrium. So because there's an obstruction in flow at the mitral valve. So when there's atrial fibrillation, this happens because there's stasis, because of reduced LV filling. So there's risk of thrombi. So these patients present mainly with exertional dyspnea, orthopnea, and they're mainly on Lasix, a beta blocker. A beta blocker is useful for them to slow the rate to allow ventricular filling, and they're on warfarin, particularly if they're having atrial fibrillation because they're at risk of forming a clot. So in simple terms, remember in mitral stenosis, you have obstruction of flow to the left ventricle that increases your left atrial pressure and pulmonary congestion, and secondary provokes atrial fibrillation, and there's risk of thrombi. So patients with mitral stenosis have got a risk of clots, and it's important. This is where an echo can reveal, because in case these patients probably need surgical procedures, defibrillating them may be dangerous. So you'd rather do rate control with drugs like amiodarone. But atrial fibrillation is a very wide topic. I can't finish it right now. It's probably another discussion for another webinar. Next slide. So this is the pathophysiology of atrial fibrillation. Sorry, no, not of atrial, mitral stenosis. So you find that, as I'd mentioned, the gradient between the left atrium and left ventricle is increased. So there's increased LA pressure, which causes pulmonary venous congestion, and you have pulmonary edema and pulmonary hypertension. So on an echo, if you see the echocardiographer reporting that the mitral valve area is less than 1, and the gradient on the mitral valve is, the mean gradient is more than 10, that's severe. This is a candidate who needs heart surgery. This may not be a good patient for elective surgery. Okay. So when you see patients with severe mitral stenosis, these are patients not for elective surgery. These are patients who need to, that valve needs to be addressed. Okay. So they may need cardiac surgery. Next slide. So these patients, when they come for elective surgery and they probably have mild or moderate stenosis, some pregnant mothers may come to labor ward having this thing, and probably they're decompensated or they could be followed up. So what happens? What should the anesthetist do? You need to avoid tachycardia. So remember, this is an obstructive flow. So if you have a tachycardia, there's going to be poor feeling. Yeah, so it's even going to make the condition worse. So you need to maintain adequate preload. Avoid hypotension. The patients prefer normal systemic vascular resistance. Where there's evidence of pulmonary hypertension, you should avoid hypoxia and hypercarbia. Hypoxia and hypercarbia cause pulmonary vasoconstriction, and that makes the right side strain. Neuraxial blockade has been accepted in this kind of patients. I have experience with doing an epidural for a mother with mitral stenosis who presented for elective CS, and it was found that she was not somebody who was a candidate for normal delivery. So we managed to use an epidural, and she was able to tolerate it. The good thing with the epidural is that you're able to titrate your local anesthetic to the effect. And lidocaine is probably what you should go with first, rather than bupivacaine, because the PK value is lower and it will work faster, especially if lidocaine is augmented with sodium bicarbonate and adrenaline. It makes the epidural block stronger. I mean, not stronger, but it makes the block dense and quite more faster. So pregnant mothers with mitral stenosis who have been followed up and need delivery and epidural can be tolerated. Peripheral nerve blocks like ankle block, supraclavicular nerve block, or you want to do a popliteal nerve block are quite safe for these patients. Where there's a contraindication to regional anesthesia, general anesthesia may be used, but this is where you need to avoid drugs like propofol. Probably drugs like etomidate may be safer, and muscle relaxants that don't cause tachycardia like atracurium, statacurium may be better, and cardiostable volatile agents like sevoflurane that don't decrease your SVR may be better. Next slide. So this is a slide you can look at this study done by Manish and Madhavi Budhi. So it was a case report on combined mitral and aortic stenosis in a patient. So you can have a look at it for further reading. Next slide. Mitral regurgitation. So what's happening here compared to stenosis, you have a valve that's able to open, but it's not closing properly. So what's going to happen is there's backflow into the left atrium, which causes dilation. And also there's going to be pulmonary congestion. And later, there's volume overload in the left ventricle. Now, because this blood, instead of it moving forward into the aorta, into the systemic, it's overloading the left atrium. So as it overloads your left atrium, so that means whatever is additional volume is there is fast-tracked or forwarded to the left ventricle. So these patients have got volume overload in both the left atrium and left ventricle. So in the long term, they get a left ventricular failure. So they present with exertional dyspnea and orthopnea. It's not surprising to see them on Lasix and enalopur. Okay. Next slide. So regurgitant lesions, you find that allowing the heart rate on the upper limit around the ranges of 90s, 100 reduces the regurgitation time. So reason is when the reason why that rate is good for this kind of lesions is the time that is spent on that blood flowing back to the left atrium is reduced when the rate is fast. And that helps with, hence it will help offset your left ventricular volume, yeah, which is already increased. So a low SVR for them is good in terms of enhancing forward flow. So that because that encourages more blood to move forward. Because already with the increase in LV volume, there's an increase in left ventricular and diastolic pressure. Now blood moves from a high pressure to a low pressure area. So where you find the SVR is low, then it will encourage forward flow. Adequate preload will be required to maintain forward flow. Hypoxia, metabolic acidosis, hypercarbia is not good in a patient who has got pulmonary congestion. Neuraxial anesthesia, spinal anesthesia is quite favorable for these patients and they're able to tolerate without issues. Where general anesthesia is needed because either neuraxial is contraindicated, cardiostable agents are good. Where the LV function is acceptable, there's no contraindication with using propofol in a patient with a regurgitant lesion, especially you find if the LV function is acceptable, an ejection fraction of 55 going up. Though sometimes in these patients, the ejection fraction can be overestimated because of backflow into the LA. So if you find the ejection fraction is less than 55, it may even be lower. It may even be 40. So these patients, if it is 55, 60, or 70, then probably their function is still good. Okay. Next slide. Patients with aortic stenosis. So there's limited opening of the aortic valve. So what happens is that when the aortic valve is not opening, so it's going to increase afterload because that means the heart is working against a very tight, narrow valve. So there's ventricular remodeling in terms of ventricular hypertrophy, and it's mainly concentric type of hypertrophy. So if there are registrars in anesthesia and they're listening to this webinar, that's a very common thing. You'll be asked by examiner to discuss this thing and describe what you understand by concentric hypertrophy. So this is where there's increase in muscle mass. And this is very dangerous because that means the ventricle becomes very stiff. Okay. So that's why you find these patients have diastolic dysfunction and they present with exertional dyspnea. As the stenosis is severe, they may even collapse and they may present with angina because this mitral valve is very tight, it's not opening. And we've already seen earlier on that your diastolic pressure is key maintaining coronary perfusion. So when there's less blood going to the systemic, then it is dangerous for this patient. So these patients are mainly on beta blockers to slow the rate. And when the rate is slowed, that means it's trying to allow the ventricle to have adequate volume and push whatever blood it has through the narrow orifice. Next slide. So patients with aortic stenosis, there's outflow obstruction. So when there's outflow obstruction, there's outflow resistance. And that causes concentric hypertrophy to maintain cardiac output and stroke volume. But that's bad because the LV compliance decreases, and that increases your left ventricular end diastolic pressure. So an adequate preload which enhances LA contraction to maintain LV filling is very important in these patients. Next slide. So patients with severe stenosis, if their mean gradient on echo is showing more than 40, or they have an aortic valve area of less than 1, these are patients that require valve replacement. Yeah. Mild, moderate stenosis patients may also need follow-up, and cardiac surgeons and the cardiologist will decide when they need surgery. Next slide. So same principles for mitral stenosis are applied here. You need to avoid tachycardia. You need a well-filled ventricle to maintain high pressure because there's concentric hypertrophy. You need to avoid hypotension because that's going to decrease your cardiac output, and you want a normal systemic vascular resistance. Epidural, graded epidural may be accepted in these patients where appropriate, or a peripheral nerve block. Then general anesthesia with cardiostable agents. So that means those that don't decrease your systemic vascular resistance and those that don't cause tachycardia are important. So drugs like etomidate are more appropriate in these patients. Opioids like fentanyl are quite good. Muscle relaxants like atracurium, cistatracurium are quite good, and sevoflurane. Next slide. This is a paper that you can read, and you can go and read. So there's this discussion: is aortic stenosis is regional anesthesia controversial? So this was a paper by these people, by these guys. So I would advise you go have a look at it. But actually, a lot of papers are showing that epidural is quite safe for this kind of patients, okay, where it is required. Next slide. So in aortic regurgitation, the aortic valve doesn't close, so there's backflow into the left ventricle. So it's very the danger with aortic regurgitation is these patients have a wide pulse pressure because the valve is not closing. Usually in normal physiology, aortic valve is the one that closes so that aortic valve closes so that you're able to feel on the coronary, the coronary ostia get blood to flow in the coronary arteries. So there's volume overload. So initially your end systolic volume increases, but later your end diastolic volume increases. So there's eccentric hypertrophy because there's left ventricular and diastolic pressure increases. So this volume overload makes your left ventricular and diastolic pressure to increase. So your LV dilates and it later decompensates and it leads to heart failure. So these patients present with exertional dyspnea and orthopnea, and mainly they're on drugs to reduce afterload, and they're on drugs to reduce fluid overload, Lasix. Next slide. So same principles of a regurgitant lesion in mitral are applied here. So you keep the heart rate on an upper limit, which reduces the regurgitation time and offsets left ventricular volume overload. You have a low SVR to give you forward flow, and then you need an adequate preload, and we need to maintain contractility. Neuraxial blocks are favorable. General anesthesia with cardiostable drugs that I've earlier mentioned are quite good. Next slide. So to put it all together, so regarding heart failure, the left ventricle is invariably more compliant than normal. True or false? Anyone can answer. The first option is false. When you have a failing ventricle, it's not compliant. Yeah, we've seen that there's limitation in your filling capacity. Then the central venous pressure should be kept to a minimum if diastolic failure is suspected. This is a false answer because the central venous pressure should not be kept to a minimum. It should just be maintained to the patient's baseline to ensure you have got an adequate preload. Allowing tachycardia is an effective way of maintaining cardiac output. May not be appropriate in patients with heart failure because it's going to increase it's going to increase your myocardial oxygen demand. I'm seeing good answers. I recognize Adan, Malim, and Sahel, and your answers are correct. Yes, that is false. Vasodilation can help restore cardiac output in a failing ventricle. I'm seeing people have said this false. Remember, afterload, when you have in a failing ventricle, a reduced afterload may help you to restore cardiac output. So that is true. So you find some of these patients on drugs like enalapril, which reduces the afterload. Okay. Then inotropes should never be used. That is false. So D is true. A, B, and C are false. D is true. E is false. Okay. Inotropes should be used where appropriate. Okay. Next slide. So we are going to conclude with the case discussion. I'll take you through it. So we have a 65-year-old male diabetic hypertensive. He's on insulin, 20 international units in the morning and 10 international units in the evening. He's on metoprolol. He's also on enalapril. He has a history of myocardial infarction. And he went to the cath lab and he was placed a bare metal stent 8 months ago. So he's on aspirin and clopidogrel. So he has been able to carry out his house duties and been able to take evening walks. So take note of this. He's been able to carry out his heart duties and he's been taking evening walks. Yeah, so keep in mind what it tells you in that history about his functional capacity. So before he suffered a fracture of neck of him after a fall from the bathroom. So he has been admitted to the orthopedic ward for elective repair of the fracture. Next slide. So what are your anesthesia concerns in this patient? So because of time, let me just quickly discuss this problem. First of all, let's go, kindly just take me back to the previous slide. First of all, we have comorbidities. So diabetes and hypertension, that means you're worried about his ongoing ischemic heart disease condition, possibility of chronic kidney disease. Then also, patient, you're also concerned if his sugars are controlled, number one, because he's taking insulin. Then also you want to be keen, is his hypertension also well controlled? So poor sugar control is a risk of it's a risk of poor wound healing for such an orthopedic procedure. When the patient's hypertension is not well controlled, there's risk of bleeding intra-op and also possibility of him getting a stroke. Okay. Then also we have a background of myocardial infarction, but he was placed a stent. So this is a patient who, if you're not careful, managing intraoperatively hypotension can make things become worse. Then we are also on drugs to control clots. We are on aspirin, clopidogrel, and we are coming for an orthopedic procedure. Should they be stopped or not? So this is now one of the things we need to find out. But there's a clue, the fact that he was put for a bare metal stent 8 months ago. So is he at a patient at risk of getting a clot, particularly if it is less than 6 months post the event? Okay, so this is where you find now the next problem. Next slide. We talk about cardiology review points. I'm seeing somebody's quick. Adan is talking about stopping aspirin. But remember, this is a patient who has, he's elderly and he has suffered a fracture neck of femur. And this is not a patient you want to stop. You want to take very long and he stays in the ward for long. So we need to talk with the cardiologist and discuss with him about these drugs. Should they stop or should they be continued? So in this case, the fact that it's a bare metal stent, the risk of getting a clot is we are at least beyond the window period of 6 months. But at the same time, because of bleeding and these kind of things, and he has been on aspirin, clopidogrel, is what now you'd need to be concerned about. So this is probably a patient, you may not have time to allow clopidogrel effects to wear out. So this is where you find that probably they could be bleeding in the surgery. So is this a patient that you need to go to theater with things like platelet concentrates or things like fresh blood, which probably may have platelets? Okay. Somebody is asking me, somebody I'm seeing has commented, you don't stop aspirin. Will what I'm mentioning here is that this is a patient who has suffered a fracture neck of femur and is an elderly. So you find that you may not have time to stop these drugs. And you find that you may not have time to have the effects to be worn off. But the fact that he's beyond the 6 months period, is 8 months, there's no reason why they should be discontinued, because the risk of forming a thrombi is not, there. And remember, we said aspirin is where you're concerned about in patients with spine surgery or intracranial surgery. So probably clopidogrel is the drug you'd be worried about in this case. So this is where you find you need to go with platelets to theater. Your key investigation. So you'd want a review of his kidney functions, so a UEC. You'd want a baseline hemoglobin and getting to know his platelet function. You also would like to have an idea of an echo and have an ECG on him. No, anesthesia technique. This is unfortunately, because we don't have time to allow the effects of clopidogrel to stop, we may need to use general anesthesia with cardiostable agents. Yeah, and we'll be very keen on avoiding hypotension. You don't want a tachycardia. Yeah, you want to maintain adequate preload. Then you need to ensure that you have got good sugar control intra-op and good blood pressure control intra-op. This is a fracture neck of femur, so you can't postpone or have time, because this patient is an elderly. The longer he stays in the ward, there's risk of him getting anemia of immobility. Then he can also get pulmonary embolism. So fracture neck of femur is something that you may not want to delay in an elderly. I'm seeing somebody has asked me about INR. INR is mainly in patients who are taking warfarin. It may not be applicable in this scenario. Next slide. So to conclude, we need to understand the pathophysiology. We need to know the patient's functional status, medication history. We aim for stable hemodynamics and oxygenation, regional and general anesthesia where appropriate, and look at your facility resource. It's important. Are these patients you're able to manage in your facility, or these are patients that need a national referral facility? Thank you for your attention.
Thank you so much, Dr. Umani. I think we all agree that that was quite educative. And I like the way you've summarized complex literature and complex issues. You know, cardiac and, cardiovascular physiology, pathology is a very complex discussion. But I like the way you've summarized the different and the most common cardiac problems that we are likely to encounter in anesthesia, as well as relating them to anesthesia and how you manage each of those common cardiac pathologies. So at this point, I would like to recognize other panelists that are present here. We have Dr. Sweetbet, Dr. Papichon Tambwe, as well as so many other senior colleagues within the profession on the platform. Kindly feel free also to chip in and make necessary contributions. So I would like to encourage our participants to raise their hands if you want to ask a question, or indeed we have a few questions in our chat box. that I will select and read to our panelists as well as the presenter to see how best we can answer them and share the knowledge. Please raise your hand if you'd like to ask any questions. I think there's already a hand. Let me just allow Simon Kangwa to unmute and kindly be brief with your question or clarification. Simon Kangwa, kindly go ahead. Yes, we can hear you. Hello, Simon. Hello, Simon. Okay, so let me allow David.
Yes, thank you very much, Doctor, for the
Okay.
good presentation. I would want to know, when should we stop administration of aspirin, since this patient will be coming for operation?
Okay,
Thank you,
aspirin.
David from Uganda.
Okay, thanks, David, for your question. Aspirin per se is not a drug per se to stop. It's actually still quite favorable. The one that you're quite worried about is clopidogrel, because of the platelet dysfunction it causes, and it can trigger bleeding. In my presentation, I would say you'd be worried about spine surgeries, or where you're having intracranial surgeries and you're anticipating bleeding. Let's say you probably would be concerned about avoiding aspirin in those kind of patients.
Okay, thank you very much.
Thank you so much, David, and thank you, Kevin, for that response. I can see another hand. Adan, kindly unmute and go ahead and make a contribution. Hello, Adan.
Yes, can you hear me, please?
Yes, please. We can hear you clearly.
Yes, I have a question. Where you do a spinal for a patient with a heart condition, then as the doctor said, you are supposed to use minimal fluids, like 250 to 300 mils. But since you have given regional anesthesia or spinal, this patient is prone to hypotension. So how can I balance by giving fluids and also preventing hypotension? Thank you.
Okay, Adan, thank you for your question. What I would like you to recall, first of all, is understand the kind of patient that you're dealing with and the kind of surgery that is probably being done. For spinal anesthesia, remember that the hypotension mainly comes about because of sympathectomy. So that means you have got pooling of your venous blood. So you need to maintain your preload. And the only way you can maintain your preload is using a vasopressor, especially if it is something like ephedrine or phenylephrine, which is there. And you also need to remember that fluids should only be given particularly judiciously in this kind of patients. And it's mainly depending on the kind of volume loss you're experiencing intraoperatively. Probably even crystalloids per se may not be very desirable because their half-life in the intravascular space is not very adequate, and probably blood may be much better. So I would advise first when you get to know the kind of pathology first that the patient is having, a regurgitant lesion will be able to tolerate a spinal anesthetic very well. And as I've said, you'd want to maintain your preload. So probably that's where you find if you notice you have hypotension, you need to use a vasopressor. And you also need to maintain ensure that you have got an adequate heart rate to kick off and reduce your regurgitant lesion time. Patients already presenting with decompensated heart failure, depending on the cause, if it's a cardiomyopathy or ischemic heart disease, probably may not do so well with a spinal anesthetic because of the very big hemodynamic changes it does. So probably an epidural may be much more favorable for those kind of patients. So you give fluids judiciously depending on the volume loss that's probably over there. And probably if there are other ways the surgeons can also try to use to minimize bleeding risks, it's probably like better. So I would answer by saying get to know the kind of pathology you're dealing with first. Thank you.
Thank you so much for those very accurate responses, Kevin. Let me just allow Chetan, before I go through the chat box, to maybe pick one or two questions from there. Let me just allow Chetan to quickly ask or make a contribution. Kindly unmute and then go ahead and contribute.
Thank you, Mr. Speaker. I have already posted that question, but I thought it was not answered, so I wanted to ask. I'm an obstetrician, so I have never come across using lignocaine with sodium bicarbonate and adrenaline as a combination. So please, Dr. Urmi, can you clarify on this?
Okay, what I meant was for epidural anesthesia, you want, because you see an epidural it takes time before it works compared to a spinal anesthetic. So one of the common local anesthetics we use is bupivacaine and lidocaine, but bupivacaine takes time. It takes time to work. So when you're doing an epidural, especially if it's an emergency CS or if it is, you want quick onset of a labor analgesia, what I meant was that combination I was talking about is if the mother is coming for a cesarean section. So for a cesarean section, if you're doing a CS purely under epidural, we need to use a large volume. So we may need to use something like 22 mils of lidocaine. And just to speed up the onset, the sodium bicarbonate probably helps with making the lidocaine go and bring its effect in the nerves, and adrenaline makes the block dense and makes the block to work fast, because now the local anesthetic is being held in place in the epidural and make it at least be a bit prolonged. But this is a topic for another time. But there's a very good material on this from Anesthesia Tutorial of the Week by World Federation of Anesthesia that talks about converting a lab epidural into a CS. So usually what I do is if it's a CS and maybe the mother had an epidural, would use 20 mils of lidocaine with 1 mil of sodium bicarbonate and 1 mil of 5 mics of 1 in 200 to make a total of 22, and would give it to start making our anesthesia work. So this makes lidocaine work within 5 minutes from giving the epidural. Hence, the block tends to work faster. Now, if you use bupivacaine, you'd need to wait for about 30 or 40 minutes before it works, because it takes quite a longer time, because its PK value is on the higher side. But that's deep pharmacology of local anesthetics that I wouldn't want to bore you with. Yeah, thank you.
Thank you so much, Dr. Omani. I think we are really benefiting from your vast knowledge and experience. I think at this point, we are running out of time, but I'll just allow one question. I'll read one question from the chat box. And this is from Anonymous. He says, what are the ideal blood pressure ranges intraoperatively for a heart failure patient? What are the ideal desirable blood pressure ranges intraoperative for a patient with heart failure?
I would say it's important first to get to know what was the patient's baseline and work within 10 to 20% of it and maintain your hemodynamics there. So whatever pressure you're able to get to keep his mean arterial pressure above 60 so that you can be able to maintain adequate perfusion is important. Thank you.
Yeah, thank you so much. Maybe one more, as I also invite if there's any comments from any of our panelists or any of our colleagues on the call. If there's any contributions or any experiences, kindly raise your hand and feel free to contribute as we wind up in the next 1 or 2 minutes. Dr. Omani, there is, I think, one last question in the chat box. In what surgical cases is aspirin contraindicated before surgery?
Patients who are having spine surgeries or major intracranial surgeries that are involving bleeding, like vascular aneurysms. Yeah. Okay.
Thank you so much. So we seem not to have any hands raised. At this point, I think it's been more than an hour and a half of discussion, and thank you so much, Dr. Omani, for this very wonderful presentation. And remember, like it was mentioned earlier, that this webinar has been recorded, and so you will be able to access it and listen through. At this juncture, I would like to invite Ngajima Hashim to just give some closing remarks as we conclude the webinar. Thank you so much.
Thank you so much, Dr. Ndaba, and thank you so much, Dr. Kevin Omani, for the good presentation. And thank you so much for the rest of the team for your time to join our usual webinar session. And I hope to see you all in the coming webinar session. I use this time to thank you so much, and I wish you a good evening for those who are ending their day, and good morning for those who are starting their day. Thank you so much.
Thank you so much, and goodbye to everyone.